those who are in the chambers, Minister, you and your team. A warm welcome to you as well, and to the members who are online and the officials who are online. Thank you very much for making this meeting. The time now, it's exactly 9 o'clock, and I'm declaring the meeting open. But before we get into the details, I'm going to give ourselves a moment of silence, and the moment starts now for reflection. Thank you very much. We know the drill by now. The meeting has officially been opened. And once again, welcome to everyone, and good luck to those who will be making the presentations. And I'm going to give over to the members to introduce ourselves. I'm going to start with myself. I'm Memory Boyson, and I'm the chairperson for the Standing Committee for Health and Wellness.
Good morning, everyone. I'm Benedicte van Minnen. I'm a member of the committee.
Thank you.
Good morning, everyone. I'm Donita Stevens, and I'm a member of this committee.
Thank you.
Good morning, everyone. I'm Leon van Wyk, a member of this committee.
Thank you, members in the chambers. I'm now giving an opportunity to the members who are on the platform.
I'm Thomas Walters, and I'm a member of the committee.
Thank you.
Good morning, everyone. I'm Rachel Van Vogel and member of this committee.
Thank you, Member Van Vogel. I think we are done with the members on the platform. Minister, I'm now giving over to you for introductions, and you and your team. Thank you.
Thank you very much, Chair, and good morning to the honourable members. My name is Mireille Wenger, and I'm the Western Cape Minister of Health and Wellness.
Thank you.
Morning, members. My name is Juanita Ardenser. I work as the Chief Director, Emergency and Clinical Services Support, and EMS is one of the 6 directors in my space. Thank you.
Thank you.
Good morning, everyone. My name is Craig Wiley. I'm the Director for Emergency Medical Services within the Western Cape.
Thank you very much. Minister, I'll give over to you for opening remarks.
Thank you very much, Chair, and to the committee for requesting this briefing on the emergency medical services in the province. I often refer to this as the thin green line between life and death. This team really does excellent work. They go above and beyond every day, and in particular when there are major incidences or major disasters in the province. Of course, we operate in a resource-constrained environment, as do most government services, in particular over the last few years of austerity. But you'll see in the presentation that EMS goes much beyond just an ambulance. It is a comprehensive service right across the province, from the most rural to the most urban. And I would just like to express at this point my gratitude for the work that our EMS colleagues do every single day. Thank you.
Thank you, Minister. And Minister, I've also received a notice from your office that you have to leave us by 11 o'clock. We know you have other engagements as well. It depends from the green team how long they're going to keep us all busy here, but hopefully by then we will be done. I'm now going to give over to either Mrs. Arons or to you, Craig, to do the presentation. Over to you. Thank you.
Thank you, Chair.
Sorry, before you start, I just see that we have some guests. Yeah, you can. Sorry to the members on the platform. We've just been joined by guests in the chambers. So I'm going to give them an opportunity to introduce themselves as well. You just came in as we're going to start. Fortunately, you haven't missed nothing yet.
Good morning, everyone. My name is Naomi Batana, and we are from the Vitzenberg Justice Coalition in Vitzenberg. The reason why we're attending the standing committee is just to raise the plight of Vitzenberg. Only has 4 ambulances for a population of 162 people. 1,000, yeah. Thanks.
All right, that is noted. Everybody must introduce themselves, please.
Goedemorgen. Mijn naam is Ricardo David. Lees de Associates.
Thank you.
Môre.
Good morning, everyone. I'm Sunil from Vitzenberg Justice Coalition.
Môre.
Good morning, everyone. I'm Angeline Saroon from WJC.
Thank you.
Goeiemôre, ek is Caroline Okkes van Ceres WJC.
Dankie. Julle mag julle mikrofone afsit. Dankie. You may continue now with the presentation. Thank you, sir.
Thank you, Chair.
Oh, sorry, I didn't see the lady right at the back. Ma'am, right at the back, if you can introduce yourself, please.
Good morning, everyone. Thank you very much for the opportunity. My name is Dr. Leslie Corey, and I'm a social worker by profession.
Thank you, Doctor. Now we can really start.
Thank you, Chair, and thank you, members, and everyone else for the opportunity to present to you what emergency medical services in the Western Cape is all about. And I'll just jump right in. There we go. So, yeah, thank you for allowing us to present the green team to you today, EMS services within the Western Cape. Just firstly, to start off with, as everyone is well aware, health services is a constitutional mandate. Section 27, paragraph 3, specifically speaks about none may be denied emergency care. 84% of our population within South Africa is reliant on the public service, as we all are aware, and uninsured. Our health system is made up of a 3-tier system, which means that a large proportion of our patients in our facilities actually needs interfacility transfers as well. We deal with a large metropolitan and extensive rural service, which is quite specific to the Western Cape. And then obviously in South Africa and in the Western Cape, we see a quadruple burden of disease in our space, which includes HIV, maternal and child health, non-communicable diseases, and then specifically injury and interpersonal violence as well. So just the infographic that I put in front of you is the emergency care systems framework as given to us by the WHO, or the World Health Organization. And this is really what we build our EMS system on. And you'll see that it starts with bystander care. It starts with the community and the access to our contact center, our emergency contact center, the response, the scene care, transportation, and then also facility or inter-facility transportation. So I thought the easiest way to go about the presentation today is to really outline what we do in terms of this framework that's been given to us by the WHO. And I'll start with our transversal services that is for the province in a whole. Just firstly, that's our structure for our service. So we have, I'm the director, and obviously within the line of health in the sector of ECSS and services specifically. We have got a total of 6 deputy directors, of which the biggest one, which I suppose we need to talk about, is the operational deputy director space. But we've also got operational assurance. Our fleet management is quite extensive and critical. Finance, people management, and then our medical services. And I'll go through those just shortly. So this is firstly just people management and finance. The people management is done from a central point. The shift system and providing services outside of our facility creates unique situations, and we need to come up with unique solutions to be able to service the needs of our staff and people. From a finance perspective, cost of employment is our largest, and I think any service's largest expense, with 2024-2025 just under 840 million spent in that space. Goods and services makes up around 360, under which the biggest expenditures is our emergency contact centers, which is communications, and our aeromedical services, which is medical contractors. Fleet services, because we are a mobile service, is obviously also a large expense in our budget. And so in terms of staffing, and really these are the people delivering the frontline work, operational services has got, as you can see there, 1,496 staff members, of which 1,100 staff members are your frontline workers in the ambulances, 59 emergency care technicians, and then the paramedics, which is the advanced life support cadre, is 182. The rest of our occupational specific dispensation staff is based within the medical rescue services, and also our planned patient transport, which is the HealthNet cadre. Clinical services also gets supported centrally, and this is run under our medical manager, which is Dr. Kirby Meyer, and they really look at the intersect between clinical management and data to make sure that evidence-based services is provided to our population, and that clinical services is monitored throughout time, and improvements are made to quality of care. Operational support and fleet looks at our, firstly looks at our ambulance service as a whole to ensure that the service is registered according to legislation and policies and prescripts. As you know, the Western Cape government is the only province with a Provincial Ambulance Act. Nationally, there's regulations, but the Western Cape is a Provincial Ambulance Act, and all of our public service ambulances also has to be registered and inspected by the inspectorate. The space is also responsible for provider management, such as our aeromedical services, AMS, and where we do use private services then as well. Fleet is responsible for the upkeep of our critical ambulance fleet. Just in terms of our ambulance fleet, I've just put some pictures on the board just to explain slightly. So you'll know the normal ambulance, which is ambulance 27 there, and that's what we'll see every day. But in some of our rural areas, we really do have problems with access. So we do have 4x4 ambulances as well, which is specifically designed for those areas that's difficult to access via road. Our rescue services are, there's about 100 of our paramedics employed in the rescue services, and they are specially trained to access patients and to extricate patients from places where we can't provide medical care, to ensure that we can provide the medical care. And then, as you would be aware, we also have been dealing with quite a couple of major incidents over the last couple of months specifically, and over the year or so. If you think back around the George building collapse, the bus accident that we had about 2 weeks ago, and our rescue services do provide that major incident support to the health system as well during that time. So EMS operations, which is our biggest component, and obviously the people that provide frontline care. And we start really at bystander care. And as you know, we have a emergency first aid responder service that really is about us working with the community to build resilience. In that space, there was an article published 2 years ago. We've trained more than 10,000 EFAs in the Western Cape over the last 10 years. And it also acts as a pathway to entry into emergency medical services. Ms. Isaacs, that's on the right there, has now completed her national diploma in emergency care and works for the Western Cape government. Our emergency contact centers, so that's where you call in. We've got 5 of those structurally in the province and 1 mobile center for major incidents. They are critical for handling more than 2,000 incidents a day throughout the province. The clinical desk, which is a new addition to the emergency contact center space, really looks at providing clinical care through telephonic measures before the arrival of the ambulance, to give advice to bystanders or medical personnel that's on the scene that may want to assist. This is driven by the computer-aided dispatch system that we have deployed within the province, and really speaks to the effectiveness of the province's responses to incidents. The Provincial Health Operations Centre is a centre that deals with all of the major incidents within the space and makes sure that the entire system comes together when a major incident occurs so that we can adequately and effectively transport and treat patients towards the health system as a whole. Our computer-aided dispatch system as a solution allows the contact center to assign appropriate vehicles to incidences. Emergency care providers receive the call on a mobile data terminal in front of the vehicle that allows them to book towards the scene and also navigates them to get there. And then there's a detailed electronic patient care report that gets completed in the back of the vehicle, which allows us to understand the cases better and allows us to understand the burden better within our system. In terms of the PHOC, or the Provincial Health Operations Center, like I said, they really do look after our major incidents, and they work on a principle called MIMS, which is the Major Incident Medical Management and Support Principles. They're critical to the function of a silver command, and like I said, to pull the whole system together when these system-wide coordination, when these major incidents does happen or the system gets overloaded. In terms of the emergency response, primary response is within the province, deals with incidences in the public space. We classify incidences according to priority, so ensuring that the most ill patients get the ambulance or will get a response the quickest. Medical rescue plays a vital role in the access and extrication of patients, as I've mentioned. And the aeromedical service that we have in the province allows us to retrieve critically ill patients from far away and bring them to central places as well in time-sensitive scenarios. So in terms of what our footprint, the graphic on the right-hand side is from an unpublished manuscript that we're busy with, and it shows in red. Shows in red our 52 stations as they are populated throughout the province. And then last year in 2024, we responded to 816,000 incidences within the space, and that's what you see in blue. I do know there's some in the sea, and we do calls at sea as well, evacuation specifically. We've traveled a total of 26 million kilometers with our emergency fleet in 2024. Emergency medical care, so the care that gets provided with the just over 1,000 or just around about 1,500 occupational specific dispensation providers, and those are emergency care officers and paramedics. Professionalization of the qualification occurred about 10 years ago now, and all paramedics that qualify now qualifies with a tertiary certificate, diploma or degree. OSD providers are registered with the HPCSA, so they're held to the same account as our medical professionals. Clinical treatment is guided by a scope of practice, and that clinical documentation that I showed you earlier gets used for M&E and continuous development to ensure quality of care. Interfacility transfers, so as I mentioned previously, the public sector has got our primary responses, but then we do move a lot of people within the interfacility transfer space as well. So a total of almost 180,000 interfacility transfers last year. These resources are shared, so it is not specific for interfacility transfers, so that the system can be agile to where the need is. Specifically in 2024, we saw more than 3,000 highly specialized ventilated transfers happening from hospitals to specialized care. And because of this, we have created a critical care transport team within the Western Cape that is specialized paramedics that's able to transport very small, very sick, and very sick adults as well. Our HealthNet services, or planned patient transport services, in 2024 transported around 150,000 patients. And as you can see, these staff and vehicles are across the entire province, ensuring that we can get our patients to where they need to be in the appropriate time. Specifically, we focus on vulnerable patients within our planned patient transport space, but this does differ when we speak about patients coming from rural areas where vulnerability can be extended to your ability to be transported. So challenges, just in terms of what it means to staff one ambulance, we need between 9 and 10 emergency care paramedics or emergency care officers to staff one ambulance. In the rural areas, our staff is actually very well self-organized, their ability to staff more than one ambulance at one time. So one good example is we had a bus accident 2 weeks ago on the N1 close to the Port Alfred turnoff, Prince Albert turnoff, sorry, Prince Albert turnoff. And that was about 50 kilometers away from Laingsburg and 108 kilometers away from Beaufort West, which was the main receiving facility. Our off-duty staff, at that stage, came in and manned ambulances that was at the station that was unmanned at that time. So while we say 9 to 10, in a lot of our spaces, people have self-organized to actually provide additional service. Rescuers on standby at all times for major incidents, and I think the most evident to that was the George building collapse, where we actually sent several teams up there to assist over long periods of time.
There's somebody's phone on. Okay, the members online, please ensure that you are muted. We're hearing some interference and we don't know where it's coming from. Or it's the volume is too high there with the translation. Yeah, that is just a reminder as well. Dit is om te luister. So van julle, daar is stasies vir Afrikaans ook. Dis die tolke wat daar praat. It's loud. So you may use it for better understanding. I think that one, the volume is too loud. All right. Sorry for that interruption. You may continue.
No problem, Chair. Thanks. Yeah, so as I said, the rescue or rescues on standby at all times for major incidents and will respond on a standby basis as well. Just the components of an emergency incident, it's broken up into many single components, and all of these single components together makes up a full mission time for EMS. And as you can imagine, one ambulance can only do so many missions during a day.
Once again, maybe I must have a look at it. The interpreters, can you just run another test, please? We want to hear where the volume is too high in the hall.
Dink is nou die mense met die 4 ambulanse nie. Is die ons met die 4 ambulanse nie.
All right, to the interpreters, we're just checking, please. Please let's run another test. Please say something. Yeah, I think it's okay now. Thank you. It's the pros and cons of technology. You may continue, sorry.
Thank you, Chair. Yeah, so each emergency medical call is made up out of lots of components, which I think is the most known one is response time, but all of these components make up a full mission time. And as you know, or would know, that an ambulance is only able to do so many missions within one day. So if the mission times become longer, then less incidents can be serviced. What influences these mission times? I think the best known within the city space specifically is red zones, and specifically staff safety. So police escorts results in compounded resource constraint. We know the police is also resource constraint. EMS is resource constraint. And together, if they rely on each other, there's obviously a compound. Addressing these concerns are complex, with certain initiatives underway, such as our green corridors and several engagements with the SAPS. But solutions to safety concerns should be co-created with local communities and emergency care providers. And that's really where we focus, is that we can create local solutions. Off-staff safety, a big concern for EMS, remains mental health of our providers. These providers have to go out to uncontrolled traumatic incidences outside of four walls. So they don't know the area that they're going into. And then to be faced with a traumatic incident really does have a significant impact on your mental health. The department and Western Cape government has employee assistance programs, which is really good and really engaging, but mostly reactive. And we have to start focusing on the physical and mental health of our providers pre-employment and throughout the length of their employment. Staff safety is directly linked with staff wellness and mental health. Then around retention of emergency care providers, and you'll see largely my focus on the challenges is our providers, because we need providers to be in ambulances to be able to service incidents. So the brain drain continues to reduce our workforce, and specifically in the Middle East. Similarly, staff appointment in rural aim to staff appointed in the rural space often aim to move towards the urban space. We cannot compete with the salaries and workspace or workplace safety and workload of the international markets. But what we can do is we can ensure that there's career advancement, there's a work-life balance. We recognize our emergency care providers for the good work they do. And we support for training, especially in the postgraduate and the spaces that investigate how we could do things better. But more than all, the sense of belonging needs to be there. And that's really why we are here today in our uniform, is to show that we are part of the teams, and to uplift them is to be part of them. Thanks.
Thank you very much for the presentation. Members, I'm going to now give an opportunity to yourselves for any questions, comments, engagement, and then I will make another round again. Member for Manen. To the members on the platform, I'm going to start with the members in the chambers, and then I'll come to you. We see the hands on the platform. Member for Manen.
Thanks very much. And thank you very much for the work that you guys do. I think particularly in the rural areas. And that's really the basis of my question. You talk about the brain drain. Are you talking about the push to move internationally or into urban areas or into the private sector? I mean, how do you really deal with certainly something we've come across with oversight? You mentioned Beaufort West. There appears to be a big issue with getting accommodation or adequate accommodation in a lot of rural areas in terms of costing, in terms of that kind of thing. So what are really the factors that push that brain drain? And where do you find that people are going? Thanks.
I'm going to take about 3 questions, and then you guys can respond. Member van Wyk.
Yes, thank you. I'd also just like to compliment the entire team for the work that you do and continue to do. And, you know, knowing the George Building disaster site where I personally spent a lot of time, and I know what work went into it. Has anything been done to catalogue or to sort of describe the work that you did there? Because I think it was a world-class event that took place, and that rescue, that was something unbelievable. I know from I think it was Selga, who then looked at the level of communication that went out in terms of the communication management on that. But I think we tend perhaps not to recognize the rescue work that was done and the level of commitment of that team that was involved there, and you know the 24-hour days that were worked over that period of time. And I think there's, you know, maybe there's some thought that needs to be done from that perspective. I suppose what we have noted on a number of our site visits and since last year have been the descriptions of, call it the shortage of vehicles, the shortage of staff, and the type of stresses and strains that have been described. I know certainly I remember, I think there was some comment in Knysna, some comment in George, certainly in Beaufort West that I can recall where that level of comment was made, and you know certainly I understand the type of pressures that that one has from a funding perspective. I just also did a quick calculation here on your budget of 1.4 billion. And that roughly works out at about 200 Rand per year per citizen in the Western Cape. And then I say to myself, you know, that's all that it really costs per citizen. And, you know, it should, you know, how else does one perhaps fund an emergency service like this? Not that I've got any answer, but, you know, maybe it is some thought that one needs to have in terms of being, let's just call it a citizen of the Western Cape, that for 200 Rand a year, you've actually got the service that we do have, the excellent service that we have. So that, I suppose, are just a couple of our perspectives. Thanks.
Member Van Vogel.
Thank you, Chair. Let me also welcome the presentation and the Minister. It's also so the importance when you see the Minister is part of the team. It shows that he really cares about our people. I normally say when I engage the EMS team, you are the most needed, but one of those most hated people. The reason why I'm saying that is it's actually nice to hear good things about you, the EMS services. When my colleague point out some of good things that you guys are doing, not to say you are not doing goods. Perhaps we as the department or as politicians are failing you, or you are failing our people. So perhaps that's one of the reasons why we call you in, to understand the operations of EMS. And what I pick up, the challenges you are facing at the moment is shortage of ambulances, slow response times, shortage of trained paramedics, and then safety concerns. So that's the issues when I engage in the community. That's the issues that we pick up. Remember, when anything happens, call the ambulance. So you are the most needed people, but what is the problem that the community are not embracing you? So we need to look at ways, how are we going to, for your safety, and also in order for you to serve our people, what are we going, or what are the department doing to overcome that, to at least build that relationship between EMS and also the communities. Chair, then I want to understand, I think in the presentation there's something about 9 to 10 paramedics is required to staff an ambulance. It's a lot. So perhaps if you can explain, is it per shift? Are you dividing it per shift? So if I can just get the explanation. Then, Chair, also, if I'm not mistaken, I think I missed a part. The Western Cape, I think are you saying we have, how many ambulances do we have? Is it 120 or is it more or is it less? And then I also want to understand, because my understanding, you have a response time of 30 minutes, if I'm not mistaken, perhaps more, but it takes normally, it depends on perhaps areas, but I was a victim of a family member of mine was a victim of calling the ambulance the afternoon. The ambulance arrived the next morning. So now I try to understand how does it make sense. And there's a lot of such issues where ambulances in the rural areas, I also want to understand in your rural areas, how many stations do you have out of those stations, how many is in your rural areas, and which areas are they covered? Which areas are covered by those stations? Then also, I have this feeling that I'm not sure, perhaps it's the politicians of the department. There's no really that care when it comes to the rural people. And we really need to look, because most of the time, everything is into the matter. I know that it's the most densely populated areas, but it's always the plattelandse mense kry scraps. It's a biggie there, biggie here. So we really need to, I want to understand the rural areas in terms of your service points. I think I will park there for now, Chair.
Members, please allow me to make this the first round, and then I'll come back for a second round. Mrs. Abrams and Craig, you may decide on the responses, please.
Chair, I think before we go into the specific questions and the responses to those, I think it's important just to sketch the context, the broader context in which health is located. As the honourable members will know, South Africa is, coming through a fiscal crisis where the economy is not growing, which means the tax revenue is declining. And in 2023, in fact, we had a fiscal emergency and all our budgets were cut significantly. And we're still recovering from that. As a province, we have prioritized health. And if my memory serves, health takes up approximately 34% of the entire Western Cape government's budget, which shows that there is a priority for health. But despite that, even in this year, in terms of our staff, we're not in a position to grow yet. We're building back, but we're not yet at the place where we can say we are growing in terms of our number of employees. So what does that mean? It means that we have high service pressures, and we have to do more with what we have. So we're working very hard at making sure we can be as efficient as possible. And in particular, for example, in the EMS space, we've just recently launched a think tank with the private sector, which is working on specific things that will help, for example, in the EMS space. Let me give you a practical example, and that lies in imaging. If a patient presents at in a rural area, and they're then taken to the district hospital, if that hospital does not have sophisticated imaging capability, for example, a CT scanner, the ambulance will then take that patient to the nearest facility that does. And sometimes that could be as far as 2 hours away. That means that ambulance is now taken out of circulation to help that patient to get their scanner and then return depending on what the results of the imaging showed. Which that then puts pressure on the remaining ambulances in that area. And also depending on the day, is it a weekend or high pressure times, then it means that the waiting times will go up. So we're saying, well, is there a way that we can partner with the private sector to make use of imaging services closer? So there might be a private hospital half an hour away rather than 2 hours away? How can we use that service, which means the ambulance will be out of circulation for a much shorter period of time, which means the resource stays in that specific area? Now, it obviously seems quite straightforward and logical and the right thing to do, but to get it done is a little bit more complicated. We have PFMA requirements, the Auditor General, etc. So we have to make sure that however we go about it also meets the governance requirements. But I can assure the committee that we're working very hard on unlocking these solutions, which will help almost immediately once we've got it over the line, and then we'll be able to assist many different rural areas through this project. So those are the kind of things that we're looking at in efficiencies, and there's multiple other types of efficiencies that we're working on. But ultimately, efficiencies can only get us so far. So what we ultimately need is actually for health financing in South Africa to increase. So, I mean, we're not the only province that struggles with this. Other provinces have the same issues. And so we need to have then a conversation about how we fund healthcare in South Africa. How do we drive efficiencies, but also where we do need to look at how health is financed, then we should do that. So that's just the kind of broader context, and just to kind of then ask colleagues to go into the specifics.
Thank you, Minister. Mrs. Harrensen.
Thank you so much, and thank you for the questions. I'll kickstart, and if we can do a bit of a tandem just to make sure that we cover everything comprehensively. So maybe just to start, and I'm not going to repeat anything the Minister said, because I think that just gives a knock on basically everything you've asked. But just to respond specifically to the brain drain issue, and I think it's a combination of all that you've mentioned. So internationally, for example, Saudi, right? I think just competing with those salaries in Saudi is a challenge. And we have a lot of young paramedics also. They haven't got, sort of families. And so they go abroad and they experience life. And then there's the financial sort of benefit as well. We also have people going to private sector, although that's not such a big brain drain. I think the international one is the biggest one. And then the other one is that we often have to employ in the rural spaces some of the people who live and work, and his families are in metro areas. And they accept posts in the rural spaces. And as soon as there's a post available in metro, then they move back to be closer to their family. And that's understandable. And that maybe ties into the next point that Member Windvoogel mentioned about just the rural spaces. I think that the context in rural is... So first of all, let me say, I don't believe that we neglect the rural spaces, but we are so challenged in the rural spaces. And I'll maybe just give one example about schooling and education and the the subjects that you require to be able to study further. That's one of many reasons also. So we find that even though we can train a lot of EFAs, emergency first aid responses in those sort of geographic areas, and we can build that capacity, not all of them can transition to further education because they don't maybe have pure maths or they don't have any of the subjects that's required to be able to study further than maybe a basic sort of, program in emergency medical services. It was one of the challenges. What we've introduced is a program to try and look at some of the subjects that some of them do have and enhance their sort of their percentage that they attained, in school. So we do that as well. But even that is a challenge because you've got to release somebody now from a rural space for a couple of months period to be able to do that program, and then it further sort of limits what's happening in the rural space. So we have started engagements with WCED to say, what can be done there in terms of science, and those kinds of things. And they're also challenged with the fact that teachers don't necessarily want to work in, rural spaces, so they maybe don't have teachers for all of those subjects in rural spaces. So some of the schools will be able to offer it for a period of time, but then they can't offer it for a period of time because then I lose that expertise in that teaching skill and so on. So I think there's a few things that makes it challenging. And like I said, I think a lot of people then apply to rural spaces, but when the foot's in the door and something opens up in the metro, then there's that shift. But it's an ongoing thing. So we try and enhance the results. We engage education department. We try and work together, build the EFAR capacity. We try and make sure that when we also look at our norms and standards, and I'm mindful of the volumes of patients and our population is increasing, not necessarily how we can even plan or foresee it. Populations just, grow as everything, I suppose, happens in that community. So you can't preempt it. You can try as best as possible. So we work according to norms. Our norms in the metro is different to the norms in rural, because in rural we have to consider the travel times and the distances. There's maybe lesser population, but then there's other caveats that comes into play. So maybe just to reassure that we are looking at the norms and standards. I think the issue on safety and slow responses. So if you look at the red zones, for example, in the metro particularly, there is a need for SAPS escort or law enforcement escort, especially in the red zones. A red zone is not declared globally. We're trying to move away from red zones and look at, green corridors and trying to change the narrative, make it a more positive narrative. But the truth of the matter is that there are certain geographic areas where we are challenged, and the crews do experience attacks from the very community that they serve. I'm not saying it's all the community, and there has been a lot of engagement at the community level through those community action networks to look at how we can build relationship, strengthen relationship, have conversations. Then it helps for a period of time, and then so it kind of goes through the ebb and the flow like anything does, I suppose, in a community setting. But there is definitely ongoing effort to strengthen those relationships at that level, and maybe also then to say that there's also EMS doesn't work in isolation, so there's a close connection with the rest of the health system. So the day hospital services, the community health services, the NGOs, etc. There's a close link with that, because those are that's a tacit knowledge on the ground. We move across the platform as the patient needs are, but the guys who are stationed there also understand a lot of what's happening in the local communities, and that's also helpful for us. So we work on those relationships as well as the rest of it. And then maybe to come to your point on the 9 to 10, you are right, it is shifts. So there will be 12 hours, but then there are going to be opposite shifts as well. So it's 2, 2, 2, 2. So that's 8. And then, of course, you always need a person, somebody so sick, maternity leave, for whatever reason that you have to cover. And you're always using that last person. And then often we can have those gaps filled, across the platform. I'll be honest with you that we do need 9 to 10 per shift, per ambulance, per vehicle. But in all honesty, in some areas, we don't always have 9 to 10 because it's the recruitment issue, it's the attrition issue, and so on. And then maybe just the point that was also raised about major incidents. So maybe just in general about major incidents. If after every major incident, there is always a debriefing session that gets held internally with the local management team. And I know that the director also often joins in on those major incidents, sort of almost like what we call a debriefing. And the debriefing looks at the response. It looks at what are the lessons that have been learned out of those responses. It looks at what went well, what didn't go well, what should we think about doing next time. But it also looks at how people coping and how does employee health and wellness comes into that space. And then also we do have regular sort of recognition ceremonies for various things, not just for major incidents, but we make sure that we build that into how we recognize people for years of service, for response to specific incidents. Like if we look at the George building collapse as an example, and we work very close with our communications, ministers' communications, as well as the department's communications to look at how, we look at media recognition and all of that. And often we don't have to try to do that because that often just sort of happens as a natural consequence of that. I don't have an answer for you in terms of the 200 rand per year per citizen and how one can think of financing anything different. I do think that ministers has given us a nice picture of where we are at in austerity. I think we're all really, desperate to get out of the situation that we're in, because our reality is not stagnant. And you are right when you say that the first person to call in any emergency is the ambulance. You are right. And often the ambulance is not necessarily the right place to call. But our communities don't have vehicles. They can't pay. I mean, my husband's got family in Teslarsdal, for example. It costs any family member 600 rand if they want to get to that one person who's close by with a car to bring them through to a hospital outside of the Overberg, for example. People don't have that kind of money. They're living off SASSAs, disability grants, all of those things. So I think that we sit in the situation that we sit in, not just for EMS, but as a health system, as the knock-on effect from the social determinants that determine what is going to come our way. It's poverty, it's unemployment, and those struggles in a post-oppressive society is real, that we're still dealing with it 31 years into democracy, and it's something that we should all try and work towards, growing jobs, etc. I know that's a priority focus area of the government as well. So we deal with that. And often the need is just transport and not necessarily an emergency vehicle. But we don't say no. And as Craig explained, we also have the clinical test to try and assess, how we can give guidance telephonically as well in those circumstances. So I'm going to stop there. I hope I've tried to touch on as many of them as possible. And maybe I'll just ask Craig if you'd like to maybe add to anything. Chairperson, if that's okay with you.
Craig, you may add if there's something to add.
Thank you, Chair. I think thanks, Dr. Orense. Definitely a very good outline of our current events. I think from my side, the only thing to really add is what is our job in this space. And I think members brought it up. It's that 9 to 10 people, right? 9 to 10 people is what we need to adequately staff a 24-hour ambulance at any given time. And my job here is to make sure that those 9 to 10 people are supported and are at work. And we do that through, like Member said, Van Wyk said, is by recognizing them, by creating an area of belonging, and by keeping them safe. And I think a lot of the things that we do in that space is like that is what gives us ambulances, is the people that's going to work on the ambulances. The only other thing that I can add to Dr. Orense's reply is that our relationships with our external partners is super important. So we've just come back from a national engagement with some of the HEIs, the higher education institutions, where we spoke about feeding programs, where we can take people that doesn't necessarily have maths, science, etc., and take them into a feeding program into the higher certificate, which is the NQF level 5 qualification and the entry level. And we're able to actually then provide them with the education. So that's that we're doing with our partners within the higher educational institutions. And then also the answer to the George collapse is there is a lot of research with our academic partners happening within the EMS space, where we're looking at stuff like how to better respond, how to prioritize our calls better to get to the most ill patients the quickest. The graphic that I showed you around where our calls are and where our ambulance stations is, and to optimize that space. So I'm willing to share some of those academics' names, and you can look up their work that they've done as well. Thank you. No, I can. Chair, should I put the map back up?
Yes, please do. Members, after the map has been shown, I'm going to allow for a second round, and then I'll come back for follow-ups.
So at the moment, the city of Cape Town has got 4 mega stations within the city of Cape Town, and those are the sub-districts as you know them, and they're based in the sub-districts as you know them. The other 48 stations are within the rural space as we know it, outside of the city of Cape Town and the other 5 districts. In terms of staffing, more than 50% of our staff is actually based within the rural space. And also in terms of management capacity, we have gone out to ensure that the management capacity within the rural space is at a much greater percentage than that in the in the metropole space. For instance, as an example, if you look at our staffing, we would not have sub-district managers within the urban space, but in the rural space, we do capacitate that level of management because of the vastness of the area specifically. What we do see is because there's 48 stations in the rural area, often stations in smaller towns will only have one ambulance within that town, or one staffed ambulance. So what we do, for instance, if you go up, just to zoom in a little bit, in the Bitterfontein area, we currently have 8 staff members there due to difficulty in recruitment rather than positions being available. And in that area, we can run one 24-hour ambulance. But the staff that are on off duties actually go on standby. And if that ambulance comes in, is out when there's an emergency, these staff will come in and crew a second ambulance that's standing at the station ready and waiting for them. Or if the crew come in on duty and the crew that was on duty is currently doing a transfer to Cape Town, which we know can take a very long time, that crew coming on will take the second ambulance and actually be able to make that ambulance operational. So ensuring continuity for the emergency response within the area. To answer your question directly, member, we have 1,149 staff members that's allocated to our ambulance operations, OSD ambulance operations. So that means that we can put on duty at a 24-hour time period around 110 ambulances according to, or just over 110 ambulances according to the metrics that we've given you. Knowing that we do use overtime in areas that feel significant stress at a specific time, and that our rural space has got standby crews as well, that number does fluctuate. And that number does fluctuate based on call volume. So call volume during the day is busier than in the evenings. So we would move some of our evening vehicles to make sure that we cover better over daytime. Thank you, Minister. I think.
All right, I'm going into round 2. It's Member Stevens, then Member Walters, and then Member Jacobs, and then I'll come back in that sequence.
Thank you, Chair. My question is, okay, I didn't really get an answer on the time frame of an ambulance, the average response time. I know we sit here and we discussing what's in front of us, but what is the response to the community? I'm talking now on behalf of the community, because I made a call myself 2 weeks ago at 9:15 for a person that had a stroke not far from where I stay. I made that call around about 2:09. 2 hours later, I had to ask somebody to take that person to the day hospital. There we know if you don't come with an ambulance, you wait forever, you will die outside the day hospital. And so that's actually what happened to the patient. The next morning, when I got up, I saw there was a response from the ambulance. The message that said they're outside my house. But that was like 3:30 the next morning. And the call was 2:09, was like 6-7 hours later. So the average response time in the Western Cape, the rural areas, in the urban areas, I really would like to know what is the response time for an ambulance. And especially now with the gang war on the Cape Flats. That's also, I know it's making it worse. It's putting a lot of strain on your guys' work. But it's also putting a lot of strain on the normal person that's not part of the gang wars on the Cape Flats. That your strokes, your heart attacks, the people that's going into labor at the houses. And then my other question is, I can see when I look at all these figures here, that was in the evening. In the evening, yes, that was 9:15 in the evening. So the next morning, 3:30, I got that message on my phone. The ambulance is standing outside my house. I was sleeping that time. And when I look at the figures, I mean, this is not only something that's coming on now, the shortage of ambulances and staff. That was even before lockdown. A lot of things gets blamed to lockdown. Lockdown was like 2 years, 1.5, 2 years was lockdown. This shortage of ambulances and the proper staffing is like long before lockdown, and it's still continuing being a problem. So my next question towards that shortage and that ambulance shortage, whether it's rural, urban, metro, the whole Western Cape, it's got the same problem. And I think that's also the problem in the other provinces. But I'm talking on behalf of my province when I'm staying in. How much of the provincial health budget is allocated to EMS annually? And has the EMS received additional funding or relocation in light of increased demand of the emergencies, especially in the Western Cape? Because seriously, we need to do something. People are keeping us responsible for what's happening around us. And when somebody knocks on your door, whether it's in the middle of the night or during the day, they expect you to help because they say we voted for you to render service to us. But most of the times we don't have answers. You phone the ambulance, you sit there with that patient or you waited with the patient most of the times, but by the time there's a response, that person is gone. So thank you very much, Chair.
Member Walters.
Thank you, Chair. I have two questions. I think a lot of the questions that I had were covered by previous questions, but there's two, call it systemic questions that I want to ask or relating to the systems at play. And I'm also accepting that it's not necessarily a crisp answer. What I'm really after is to have a sense of what conversations have been held and what directions it's going in terms of the questions that I'm asking. The first one is, Chair, in our oversight, we've noticed that there's different categories of hospitals with different capabilities and different services that they provide, but there's not always a neat fit between the different tiers of healthcare in terms of what the need is on the ground. I think it relates to, let's say, some of the distance issues, what type of care can be provided, and it has an impact on how matters are managed at the various hospitals. Is the current model of what services are provided at what hospitals, is that currently under review? Is it something that is being discussed in terms of perhaps, and I understand that there's costs involved, but perhaps changing some of the services provided at for example, Beaufort West, I understand some services they can't provide, so people have to shoot through to Cape Town with ambulances. Is it possible to relook at that model? What is the conversation currently taking place there? And then the other issue, which I think goes beyond just healthcare, the retention of capable staff in rural areas. Is there a transversal conversation taking place currently in terms of looking at what incentives can be provided to retain capable staff in rural areas? Is there a transversal conversation taking place? And Chair, this is, I don't know whether this is viable, but to use an example, is there a conversation taking place, for example, with in terms of further education, in terms of housing, in terms of selling the attractiveness of perhaps staying in rural areas? Are there conversations taking place around those two, I would say, strategic, systemic issues? Thank you very much.
Thank you, Member Jacobs.
Thank you, Chair. Thank you. Greetings to all. Chair, I think I'm basically covered by Member Van Poorgel. You know that I took a bit long, but I just wanted to say, I heard what the Minister said with regards to funding that was cut and all of it. But I think with this new financial year, the Minister has given us a little extra, and it depends on where we want to use it. Now, Chair, I want to say, sometimes, you know, we focus on beautiful facilities and all of it. And let me take you back to Verliesdorp, you know, beautiful facility there, you know, we went there. And then just when I spoke to the the normal community there and the workers there. They said, sir, this is a beautiful facility we have here, but we don't have enough ambulances here. Because just 2 weeks ago, a police officer died of a heart attack because the one ambulance was out and then there wasn't another ambulance here. So I'm saying, yes, sometimes we say that there isn't budgets, but when we do have budgets, we must make sure that we spend the budgets at the place that is needed the most. And from what we can hear, we always hear that we are under-resourced or we don't have the human resources. So I think second time around, Chair, we must make sure that we spend the budgets correctly. And then I want to say to our EMS guys, I don't know if it's true, but I've got a lot of messages from drivers also that is driving for EMS saying that when they get a fine, then they must pay it themselves. I don't know if this is true, but I just want to get it through to the guys. And then they're also alerting me to say that most of the times the systems, that they're using within the ambulances, it's faulty. So they can't really communicate with the hospital to say, but this is happening with this patient that we're bringing in. So that is just my 5 cents that I wanna put in, Chair, is to say that when we have budgets, let us spend that budget correctly. Thank you.
Thank you, Member Jacobs. Minister, you may decide with the team on the responses.
So we'll, respond to the specific questions, as well as the response times, and then staff retention, and then some of the particulars. But I thought maybe it would be helpful if Mr. Wiley could maybe just sketch a scenario, so that would just help sort of understand what an ambulance crew might face on a particular day. So, for example, if they're in a red zone and they need to wait for the police escort, what does that mean for the response times? But, it can take 2 hours for the escort to arrive. That means it will take 2 hours to get to the call. It might mean that the person, like in Honourable Stephen's example, has found an alternative way to get to the hospital, but now that call wasn't cancelled. So they still make it to that thing, which then means that they're delayed for the knock-on. And I don't know, I thought it might be useful just to sketch what is the dynamics. What might a crew face in a shift that has bearing on how quickly one can get to the service. But then also, what are we trying to do about it, to try and improve it? And then I'll just have a look at some of the information I need to source for the questions that I can't answer immediately.
Thank you, Ms. Minister. I think Dr. Orenz has got a couple of the answers around the APPs and so on. So the day in the life of a paramedic is very hard to explain if you haven't lived it yourself. We make considerable effort to ensure that we get out there and actually spend time firstly serving the population, but secondly understanding the day in the life of a paramedic and what the challenges is that they actually get to. So, I must say gratitude to my boss and the HOD and the DDG services that also spend time out there actually driving in our emergency vehicles to calls. So just in terms of a general day, and I think it's very different between urban and rural. In the urban areas, our crews will come on duty in their mega station. They will need to quickly do their handover and takeover, deal with all of their PM issues, deal with all of their queries to people management or to finance that they need to make around uniforms, etc., etc. Generally speaking, they've got about 15 minutes to do that, and then they need to go out. In the urban area, our ambulance crews will do between 10 and 12 incidents a day. Okay. Now, in the past, that meant that you could get 60 minutes per incident, and you could get that done. Okay. At the moment, we get around 2,000 escorts per month from the SAPS in the urban area. Waiting times at those for SAPS escorts can sometimes take more than 60 minutes. Okay, which you can then imagine to still do your 10 to 12 calls a day, you now need to do more than one person per call. We then have to interpersonal relationships, and as you know, the community, rightfully so, will get quite angry at our ambulance staff, our ECOs, because it's taking them so long to get there in the first place. So we see this negative feedback loop occurring where it takes longer, people get angrier, the mental health of our staff takes a significant decline because people are angry with you because you're fighting the whole day. Okay. And then staff go off. So now all of a sudden, 9 to 10 people per ambulance, you need to get new 9 to 10 is not possible anymore. So then ambulance numbers drop. And I think that really speaks to your concern in the urban area around why do we wait so long? Because we are placed in a scenario where we have to prioritize. We have to say, how do we identify the most sickest patient first to go and assist them first? And it's not because we want to do that. It's because we're kind of forced into that space. In the rural areas, it is a different scenario, like you've explained. An ambulance in Beaufort West might come on duty. They often come in early because the trip between Cape Town and there and handover and takeover will take them more than just one shift to do. So they'll be away for 14 hours. The planned patient transport routes it can take up to 20 hours from Beaufort West. The staff, they work 20-hour shifts, so they work back to back in one HealthNet vehicle, and they come down, they sleep for the time that the patients get seen in hospital, and then they drive back up. So that's important. How do we address this? Again, I don't think from my side, I don't think I can centrally address what the communities need within their space. I can equitably address the distribution of ambulances according to our budget allocation. But what we do need is we need an ecosystem approach where the local communities, the local services work together to make sure that the right services are the right hospital so that those transfers can be lessened to the city, means more ambulances available in the area. I think that was, but the specifics I'm sure we'll get into.
Thank you so much, members, for the questions. So I'm going to go to the annual performance plan. So the target is 30 minutes for a priority 1 client in the metro and 40 minutes for priority 1 client in rural services because of the distance. We have achieved 48% of that target in metro, and because of the other things that's outside of our control, and we've achieved 82% out in rural. Right, and I will anecdotally state, and I'm sure there's enough evidence for it, that a lot of the reduced achievement of that target in the metro is because of the red zones, and we have to wait for escorts. As Craig mentioned, when we often do night shifts with Craig and the team, not just to show solidarity, but really to gain insight into what it is that they're dealing with so that we can think differently about how we respond to the challenges that they face. And we've experienced it ourselves where we rock up at a police station and there is only one car or SAPS vehicle for the night, and you've got to wait till that SAPS vehicle comes back in after they've attended to something, and then they escort you to the client. And those things are sort of out of our control. I suppose the other thing that I maybe just want to flag is, even though we're setting up a clinical desk and even though we are training our call takers to ask the questions to determine priorities of the clients, you find that a lot of the clients exacerbate their symptoms or exaggerate the symptoms, or they paint a different picture, and when they arrive on scene, it's completely different to what the call has received. But that means that another client who really is in that situation now waits. And that is also something we've been trying to address through communications and all of those things. I think the question on the percentage of the department's budget that comes to EMS, 1.4 billion against a 32 billion budget. So that's about 5% of the budget that comes to MS. And then how that gets distributed, like Craig explained, all those factors get taken into consideration before the distribution happens. If I think, just to respond to the issue on infrastructure, I know that Department of Infrastructure, they have their own budgets and there's National Treasury allocation for budgets. And I suppose infrastructure upkeep is also critical, but that doesn't necessarily mean that we can take those budgets and choose to put in more staff, because just of the way the fiscal space and the PFMA works, we don't have that kind of leeway. I'm going to ask Craig to just talk about the fines issue, but maybe before we go there, I think the one member asked a question about the model of service. Is there a review process, and when does that happen to determine what is needed where? And so the department has moved. Well, let me say that reviewing how we deliver services is an ongoing thing. I don't think there's a date to start or an end date to how we review services. It's an ongoing thing. And we've moved towards a health ecosystem approach, and a community-oriented primary care approach. Now, the community-oriented primary care approach is more like a localized response, where the teams come together, government entities, non-government, private sector, and they come together at regular intervals, and they look at the things that influence what lands on our desk. So, in other words, the social determinants of health, the needs in the community. Is the need HIV? Is it pregnancy? What are those issues? And they collectively look at how they're going to be responding to that. But those COPC local level engagements form part of a health ecosystem response. So you probably heard about the rural east and the rural central and the rural west, and then there's Metro East and Metro West. And so the whole what we're trying to do with that is to not just look at what is in my small corner, in my hospital, or in my day hospital, or in my ambulance, but is to look at how all of those entities come together within the geographic space, which is often the care pathway of the client, to see what the gaps are and how we can, let me say, pool resources to be able to respond to those needs. And that's an ongoing thing. So there isn't a start and an end to that. That is an ongoing mechanism in terms of how we address that. And then I think maybe, Craig, I think the issue was just a question about the fines that was asked, if that's okay with you, Chief.
It's okay with me, Dr. Arndt. And also, just for our understanding, in the red zones, do you start at the police station before you get to the address?
That is correct, Chairperson. So if an area is declared unsafe, a red zone, because an area is not always permanently a red zone. Some of them are, like more often than not, and some are declared for periods of time when we get reports that there's active shooting or whatever is happening, and it happens quite often in certain areas, as I think we all are aware. So then the ambulance has to report to the SAPS first, and then get the escort to take them in. I've had a recent family incident, where the call went to the private ambulance, and we had the same scenario. It was a P1, also priority one. Ambulance also took very, very long to get there, but they said, we have to go to the police station first before we can get to the client. Thanks.
Minister?
Just add on the ecosystem approach and how important that is, because EMS works across the system. They don't just work with a specific referral hospital, it's very important that when the ambulance takes a patient to the facility, that facility is able to care for that person. And so having that keen understanding of how all of this fits together is very important, so that EMS can play that supporting role. Plus then the hospitals or clinics are able to then take over and with the appropriate response.
To our guest from Vitzenberg, I'll come to you. I'll just exhaust the members first. Member from Manen, you had your hand up.
Thank you very much. I've actually found these answers really useful, particularly from Dr. Arendse, because, I mean, on one hand, you're trying to provide a people-facing service across the province, but on the other hand, you are working within the fiscal constraints of a department and having to get essentially maximum spend for everything you do. I'd be really interested at some point to see almost a workflow chart of the average costing essentially to the department of somebody, would you say category 1 up in Butterfontein? I know where Butterfontein is, or somebody who is in Maverville and who can't even be accommodated in Beaufort, and when they use the ambulance, not the ambulance, the helicopter to fly them down to Cape Town, versus, for example, somebody in Woodstock or somebody in the Helderberg, where there is a large, provincial hospital. It'd be really interesting to see what the budget spend as well as the time spend is, because that's obviously going to have a big knock-on effect on your crews, on your availability. And it's easy to argue that, yes, we need 5 extra ambulances in location A, but if it's a deep rural area and you're only going to need those ambulances occasionally, what you're also doing is then using up resources on goods that aren't actually going to be used on a day-to-day basis. And of course, the flip side of that is the issue of the community and community perception. And in some ways, you are stuck between a rock and a hard place. You're the face of authority, very often the only ones who arrive. One can understand why frustrations from the community get directed towards EMS staff, and not always justifiably so. Often, it's because you're there, and therefore you become representative of what people are frustrated about. So I think my question really, and I'm going to bring it as a resolution at the end of the meeting, is how do we renegotiate that public space with the community so that one actually is able to develop some kind of model whereby you obviously can't expect a distressed family member to understand. That's not what I'm saying, but where one can look at how one can work with the community to build an understanding of what the pressures are, both on the community and on the staff and on the department. And just to finish off, what is happening within the department negotiating, say, with National about budgets, about funding? We know we live in a very, very constrained budget in this country due to all kinds of reasons one can unpack. But ultimately, what initiatives are there, or are there space for initiatives to try to look at how EMS funding can be improved, particularly in rural areas? Because there's always going to be the rural-urban divide. That's just an economic reality. It happens everywhere in the world. So how can one really look at trying to narrow that gap? Thank you.
Looking around, I've got some questions. Member Van Vogel. Oh, sorry.
Chair, I think if I look at the presentation, especially on the staffing within EMS, the page, it will, I would have loved to have it so that we can get an understanding. When you say you have hundreds operational centers, where are those 100 operational centers? When you say you have a communication center, because as the committee were asking, where's your head center? We were asking each other because we don't know. So if we can get that type of information, in which area, where is what, at least then we have an idea of the type of centers, operational centers, services, of communication centers, of whatever the case may be, that we know exactly. In PAL, we do have that. In Verdarsdorp, we do have that. Then I think we can just, as a resolution, request that information at a later stage, because it's not part of it's not in here. But so that we can have an understanding, what do we have and where are they? Then I also want to understand, in health we speak about, Minister, what do we call it, ideal clinics. I want to understand in your sector, or not sector, the EMS section, what will be the ideal situation in order to service our people? We will not do it 100%, but at least to get to that 60%. We must get over that 50%. So what will be, and then lastly, Chair, I also want to understand, do you have any vacancies at the moment? Because I know we met when we went and do an oversight in George. There was a very was very active. That I'm not sure if I was the manager there, Lopoti. I'm not sure, but you can see have a passion and he's in this type of work for years. And he plead with us, please speak to the minister. We forgot to inform you. He plead with us. They need ambulances, but they are saying with ambulances, there comes what? Staff. You can't just buy an ambulance and there's no staff. So we really need to look into, because really we do have committed staff, really wants to do their best, but sometimes the circumstances and the tools of trade, and that makes as if you are not working. Then, oh, was that the last one?
Yes, Member Van Vogel also, the issues you've raised, please remember that for your recommendations, because a lot of that would require recommendations.
Okay.
I don't want Dr. Arends to start giving us 100 centers, then we're going to take the whole day. We will request that in writing, and we will give you an opportunity through the minister in terms of.
Jay, just the last one.
The last one is
Just
that,
last
Member
one.
Van Wyk, all right?
Yeah, just the last. I do also want to understand when it comes to limited resources. Yeah, I'm not sure. There was this issue raised when I met some of your staff. It's more than nearly a year ago. When I met some of your staff, the issue of limited resources when it comes to essential medical supply, such as oxygen. Do you still have that issues? I just want to know. Then lastly, training. You mentioned in your presentation about you train 10,000 young people or whatever. I'm not sure if did you call them young.
First aid respondents.
Yeah, first aid respondents. But I'm not sure if they are young or old. But for us, it's important that they are trained. And if there's people it's who are available, that's good. But I also want us to be specific where. Swellendam. I know we met a lady, a passionate lady somewhere in the Karoo. But where? We need to be specific where, in which areas, who are they? So that people know in the community we can go to Rachel. Rachel is our person. Thank you, Chair.
From my understanding on that question is like, we would like to know where are they deployed? All right. Okay, we'll also ask that in writing. Member Van Wyk and then Member Stevens.
Thanks, Chair. Have we got any form of benchmarking or comparisons to what happens in some countries internationally in terms of, call it number of ambulance, number of staff compared to population? And, is there something comparable there that we have looked at, and how do we compare to that type of, those sort of statistics? And I think what you've also explained is the particular difficult circumstances that we now have here with additional safety and security issues, which no doubt complicates matters.
Thank you for that.
So, Chair, we will then, on your recommendation, provide written information on where our operational and communication centres are.
Yes.
As well as the areas in which the EFAR program has volunteers located. Right. I think it's easier than us trying to source the information immediately.
Okay.
And then I'll ask colleagues to go into the specific questions and perhaps around the World Health Organization norms and standards. That might be a good place.
Maybe Dr. Arends, let's give Member Stevens. You also had one, and then you can respond to that. Member Stevens.
Thank you, Chair. I think my question also touches on Member Van Minnen and Member Van Vogel's question. I know with all the challenges that the EMS have, is there a mechanism for public feedback and accountability that the public can go to in the communication between the EMS and the public? Yes, thank you.
Minister, yeah.
So if I may, then I'll answer that question first. We have a complaint and compliment line. We'll also share that with the committee because it's useful that you share that with the communities that you serve. We have a please call me number, we have an email, we have a phone number. So we've got multiple ways that members of the public can communicate with us and tell us how we're doing, whether it's a good compliment or whether it's a complaint, and each and every one then is brought into head office, and then it's engaged with the local teams on what transpired, or if it's a compliment to share that information with them, and they are logged and investigated.
Dr. Aronson.
Thank you so much. Thank you, members, for the questions. And I really hope that we're going to not lose some of it. I'm going to try and go back. And I think maybe there's the point that was raised about Bitterfontein, Beaufort West, workflow charts in terms of understanding, the difference in those areas. I think that's something that we can provide afterwards, maybe just to give you a sense of that. Just to paint almost like a picture for you. So we can definitely send that through. I think the big thing that ties into the other point about the EFAS, the emergency first aid responders, which I think you've raised as well, member, really that is our big attempt to try and narrow the gap within the community. However, the communities themselves sort of decide who they want to put forward, they raise their hand. We don't go out there and choose people is what I'm basically saying, because often it's trusted community members, and that's what you want. You want trusted community members that people can connect with and they don't feel disconnected with. So it's from the local geographic area. So if something goes wrong, the community often knows Auntie so-and-so or is trained. That's the first person they phone while they're waiting for the ambulance. That person comes on scene and checks things like clearing the airway, circulation, the basic things basically. And there is a short program that we go out and do in the communities. Yeah, that gets done at the local area. So that is a big way of trying to bridge that gap. The exact numbers and where they are, is we can get that, but to the extent that we can already say to you, it's not going to be accurate because people move in and out of their very own communities. So we can't guarantee that 1,000 that was trained there is still that 1,000 there. There might be 100 left or 50 left or whatever it is. And it's always difficult because they don't stay connected all the time, directly with us to say this is the people that's still available. But we kind of just empowering the community to build the next. Because at the end of the day, you kind of want the community to own that. You don't want it to be an external entity to say this is who they are and they must link to us, but you want the community to own that, and it aligns to the whole COPC community-oriented primary care approach. So I'm not saying it's a perfect science, but it's a big attempt and it has shown a lot of returns on investment already in that space. And then the question that you asked, member, about the 50%, how do we just get over the hill? I want to create already built, type of thing, as ek nou so aan dink. And I think that the truth is that there's so much we can do, but at the end of the day, we are dealing with people with the socioeconomic conditions within which our communities are, what they face. Just in terms of unemployment and poverty and all of those things will always have a knock-on effect on their need and the express need that they put forward to us, which then has a knock-on effect on how we prioritize and how we respond and the limitations we have are coming back in there. So I can honestly say that we keep pushing the mark as best as we can, but that's almost like that thing that's pushing back at us all the time. And that is why the community on primary care is almost like our next best bet, because now we're working with other community members, we're working with the schools, with the churches, with whatever else to try and help us move in the right direction. So we're hopeful that that kind of collaboration at the local level is going to help us get over the bolt, but it's that pushback that I just want to put on the table is our reality, but it doesn't make us give up. And I think you've heard from just the stories you've told, the passion. We know Mr. Jan Tola very well, and the passion there. So there's always a continuous pushing of the mark, and we make sure that through Craig's governance structures that there's that support given and strategy and the strategic planning sessions that happens all the time. So what's your reality? How do we put our heads together? How do we respond to that? That is not something that we don't wait for something to happen before. That's an ongoing thing, but it's almost like this pushback that's happening all the time that I think is really just, it's out of our control, but it's still our business. It's still our business to kind of respond to. And then I think maybe just a last point around attrition. You asked about attrition. So as a department, we've raised our our fold rate or our attrition rate. We're looking at it differently. So we're adding another 5% because we're mindful of the fact that we say we're only going to fill 94% of the posts, for example, because that's what the budget is. We've raised that now because by another 5% because we're mindful of the fact that the attrition is happening all the time. People are cycling in and out. So that 5% almost like buffers it. So that's what we're trying to do and to see if that's going to be beneficial to us. And we're watching that very closely.
Doctor, also just on the question raised by Member Van Wyk, any benchmarking?
Yeah, I think what Dr. Arends is asking me just to add on the previous one is the vacancy rate is about 5%, but that's because of attrition. So now by raising that bar, we will kind of be able to ensure that that is covered. There will still be 5% vacancy rate, but we've opened more posts that could actually be employed. In terms of standard setting, so like Dr. Arends has explained, we do a lot of first aid training in the communities to empower, capacitate the community to respond to their own space. And we are further exploring what the WHO calls the Tier 1 emergency response, which is the bystander emergency response into how do we capacitate and actually draw on that when there is an emergency. And there I'm talking about my off-duty people walking around in the street and how they get notified if there is an emergency 10 meters from them. So that space is the Tier 1 space. We're looking at really how do we capacitate that, and that's about empowerment within the community itself. The Tier 2 space is the formal or professional ambulance services in terms of the WHO's framework. And in that space, the WHO number that they've put forward in terms of number of ambulances per population is 1 in 50,000. Now, if you ask the WHO that question directly, they'll say that was published once upon a time, and they cannot dictate what the number of ambulances is for a specific community within an equitable share of a country that is different to all the other countries. And I think when we talk about international benchmarking, the same applies. Is we can't say how many ambulances we should have based on an international organization. What we have done quite successfully within the space is that we ensured that, and I think it's to a previous question about where's the brain drain is private, and coming from private, I can tell you, don't want to anecdotally from myself that I believe that the Western Cape government EMS is the employer of choice at the moment throughout South Africa. And we have made it quite effort in it to make sure that we are in the discussions with international organizations when it comes to learning and when it comes to innovative ways to provide services. We have got, we've had, and we do that through being in the room when there's conferencing happening. So throughout our service, we've got academics that works for Western Cape EMS, and they are actively involved in stuff like the African Federation of Emergency Care. We have got people that is talking to both the NHS and Queensland Ambulance Service, involved in the paramedicine societies of Australia and abroad elsewhere. So the teams are really going out there and finding what is the best way to provide services. And I can truly say that knowing the South African landscape in terms of effectiveness, EMS in the Western Cape is really effective for the resources that is allocated. I hope that, and then I think Member Wilmvorgen asked Ideal Clinic. There's Ideal Clinic. Office of Health Standards is developing the Ideal EMS framework at the moment. Under consultant Ms. Nike that used to be part of National Department of Health. National Department of Health also has input into that. So there should be a publication around Ideal EMS also coming out from the Office of Health Standards Compliance. Okay.
So that would make its round via us as well for for perusal.
Yeah, so there's that. There's Office of House Standards, which is obviously a national entity, but then there is the Ambulance Act of the Western Cape, which is published in 2012, that has got regulations and a provincial notice that dictates what it is that an ambulance needs to have and needs to be to operate as an ambulance. And to your question about oxygen, there has to be oxygen on an ambulance for it to operate. If there is not oxygen on an ambulance, we can't operate that ambulance. And for that reason, our provision of such must be there. And if there is circumstances where it's not occurred, that should be reported and investigated, and improvements should be made in that space.
Thank you. And before I'm going to get to the stage where I'm going to relieve you, Minister, you and the team, the lady from Vitzenberg, you were burning there with your hand.
Thank you so much, Chairperson. Yeah, coming from Vitzenberg and having to travel a couple of hours, not having all the resources, but it was so important for us to be here. And I'm listening to all the inputs of the minister and doctor. I'm confused. I'm totally confused, because it sounds, coming from Vitzenberg and having local experience, it sounds like the epic world. Then my concern is on the 16th of May, a 76-year-old chronic patient woman with lung chronic issues had to wait 7 hours for the ambulance. That was the first call, 7 hours. Couple of hours later, it turned out to be 11 hours. Eventually, when the ambulance came, she was so, and you need to understand, living in the rural space, and it's good because everyone speaks about rural, if it's just rural. She said to the ambulance, "It's fine, you can leave." Not because she wasted resources. She was tired, she was cold, she was sick, and she told the ambulance, "It's fine, just leave." Now I understand that. If I had to wait, and I'm 76-year-old, if I had to wait 11 hours, I will also tell the ambulance, "It's okay, gaan maar. Ek is net moeg, ek is honger, as niemand by my huis nie, as koud, as my mans hier is en koud, so gaan net." On the 24th of May, a chronic asthma patient had to wait 8 hours. So if I listen to all of this and I listen to the first responders or the first aiders, then I will say, bearing in mind that the province know that Vitzenberg only has 4 ambulances for a population of 162, 7Y5 people, then I will say that when it comes to first aiders or first responders, we must be on top of the list. That Vitzenberg must also be on top of the list, because there's only, if the government only has 4 ambulances, and the mayor, and not the mayor, and the minister will, I think somewhere along the line, she heard about what is happening in Vitzenberg. Now in Vitzenberg, we need to fight for everything. That's why I'm saying, if the word is being used that rural people are being neglected, yes, Vitzenberg are being neglected. The previous minister will tell the new minister, we physically had to threaten the department. We will close down the hospital just to get services in Vitzenberg. Now, if you look at the one hand of the coin.
Sorry, just for the record and for me to understand,
Yes.
because what you're saying, as a department and the ministry and the committee, we will engage regarding the issues raised here. If you say Vitzenberg, where did all of this happen? Which town?
Oh, which town?
Yeah.
So Vitzenberg represents 7 small towns.
Yeah.
Which is Bella Vista, Prince Alfred Hamlet, Op die Berg, not even Op die Berg, Koue Bokkeveld, Warm Bokkeveld.
Okay.
Then we have Hamlet.
All right, I understand that. I wanted to zoom into where was the 11-hour delay and where was the 8-hour delay?
The 11-hour took place in Bella Vista. The Oma was from Bella Vista.
Okay.
The 56-year-old asthma patient was from Tulbagh.
Okay.
Now we had a meeting because we're very proactive. We had a meeting last week. Then we understood there's only 1 ambulance for Tulbagh and for Gouda and for Saren. Now, even if you look at that route is on the route almost on its way to Cape Town already. That ambulance needs to cover that. And for 3 ambulances, now if you look at the landscape of Vitzenberg, Vitzenberg is agriculture, ons het van die rykste boere daar. That's why I love the fact when people talk about ons moet saamwerk and it's private versus government and all these things. My concern that we have, and I wanted to see where's our station, because we need to phone to Worcester just to get the telephone being picked up. Worcester, which is 45 minutes from Ceres. Now, if you go to Tilburg, you will literally see, and this is why communities are angry. Yes, we love the officials because the officials bly sommer langs aan ons. Hulle is ons mense. Hulle is nie van die Kaap of van hulle is ons mense. So ons verstaan as hulle moeg is. But how fair is this? In Tilburg, you will see the ambulances are standing behind the gate. Now, the same Tilburg person needs to phone Worcester. In one stage, we told the community, vat skere en maak die plek oop. Ry dan sommer self. This is how angry people are. You can't see an ambulance standing behind the gate and you need to phone Worcester. I don't know how the official is coming there. So dit is wat gemeenskappe kwaad maak. So we're very honest when we say we are slowly here to advocate for more ambulances for Vitzenberg. We want to ask the minister, I don't know when, but since he needs to come to Vitzenberg urgently. I don't know, because the boer doesn't want to engage with us. You go to the farms, then the same EMS can't go into the farms because die hekke is toe. Hulle is so gullible, hulle maak die hekke toe. Now the same person needs to phone, kan julle net die hek oopmaak in the middle of the night?
Sorry, ma'am, sorry. Again, if I don't understand it, I won't understand how to follow up on
You
this.
ask us the questions there.
So you're saying it happens sometimes that an ambulance needs to respond to a specific farm and then the access to the farm. Okay.
The gates are closed.
All
So
right.
this is the type of things that the minister lately with us, or she knows it by now, needs to engage what is happening in rural areas. I hear Cape Town is hotspots and there's police in order. Luckily for us, we don't need police to go with, except it when it comes to the gate, because sometimes the farmers are very gullible. But then I also need to understand, if we don't have these type of things with guns, and why do we need to wait 11 hours? What is then the obstacle? Because we're not waiting for the police, we're not waiting for law enforcement. What is then the obstacle? I really want to put this on record. If Vitzenberg should be the first pilot where business can invest, then they need to test it. Because like I say, in Vitzenberg, at the one hand of the coin, you have a monopoly of 5 farmers. Hulle kan sommer die goed koop. We don't need to ask the minister to beg for money. There's monies in rural areas. Vitzenberg is nie 'n Beaufort of 'n Dorings nie. That's geld wat daar is. And the private, if you talk with them about investing in the lives of the poor, then the argument is, and we have experience, then the argument is, ons betaal ook tax. You can't expect from us to buy things. Yes, hulle kan. It's the same farmers that are bringing workers from the Eastern Cape. It's the same Eastern Cape worker that are now putting pressure on the load. What the minister says about it, it's true. And that is the reality. A patient needs to go with a half-net bussie, which is also just one. Half-net bussie to Tygerberg. Nou moet my ma ook byvoorbeeld gaan en ek het per ongeluk nie 'n afspraak gemaak because she needs to get to Tygerberg. Then they need to take out the ambulance out of the system because sy moet gaan vir haar chemo. I just didn't for example, made an appointment in Tygerberg because Tygerberg doesn't talk with Ceres, Ceres doesn't talk with Tygerberg, but my ma moet daar kom want sy moet haar treatment kry. Now, as good as they are, they take one ambulance, ons is klaar 4. They take one ambulance out of the system for the whole day. Then Mr. Felix are stuck with 3 ambulances for the whole day. So I think that we are really honest and we're not going to beg because the issue is not begging. The issue is reallocation of resources. The issue is there is resources, financial resources in Vitzenberg. It's just a matter we need to push them in the right direction. And we don't want 4 ambulances anymore. Ja, daar was 'n geval gewees toe die ambulans by die huis kom, toe hy nie suurstof het. Meneer Felix moet met hy amptenaar slaan. Because you can't be in an ambulance. En dan is hy nie suurstof. It is unprofessional, it is uncalled for, it's nothing about I'm tired. Absolutely nothing. Thank you so much, Chairperson.
I need to be mindful of time as well. And we appreciate the input that you have given to us, and also in some of the information that we will get back, for instance, the deployment of, where the 10,000 deployed and whatever. And now that you've raised these issues, we would definitely also look out on where's Vitzenberg on the thing. It's just homework. It's not a gunsling at this moment regarding that, but now that it is raised, It raises awareness with us as well. And I like the idea of the minister engaging some of the farmers there, you know, partnerships, etc., going forward. I also have an idea here that will give you gray hair, Minister, but it's something that I will throw out when I'm done with this. Say you the last one.
Goeiemôre. Ek kan niks. Alle mense kan nie verstaan nie.
Praat vinnig, die minister gaan nou loop 11:00.
Sometimes ndihamba all over phofu manditsho apha eKapa. Xesha elininzi ndihamba kakhulu indlela.
All right, members, I understand that. I don't know whether you want to listen as well, but
Ndihamba kakhulu le ndlela. Ndihamba nobusuku ndifika ebusuku endlini. Ndivuka 3:30. 3:30 ndiyavuka. Ndithatha abantu babheka eBellville. Khona le taxi ithatha abantu babheka apha eSibhedlele. Apha enantsi eBellville. Esibhedlele esikhulu. Tigerberg. Ngenye imini kuyanetha. Lo mama umile nomntana. Ezama iyanetha imvula. Ndibuza kulo mama uyaphi uthi ulinde iambulance.
ebese ifonele.
Uloku andiyazi bayenza njani ingathi ufumana i-appointment.
Okay.
Dani bayilinde ezama. Nezitophu zakhona iambulance kwazi ukuthi ichole nje, ichole ihambe. Siphuma makunya ke ngo5 Ceres. But ngalamini ngilinethe kakhulu imvula la mama umile pha. Ndibuze lo nantsika le la mntu uqhuba iambulance. Uthi ba la mntu igcwele inantsika transport. Isi sprinter, eza sprinter ezincinci. Igcwele nami ndiyibona igcwele. Ngoku ndizibuze bani mandithini konke lo mama. Lo mama uhamba nomntana inyanzeleke ibe phaya. Undicelile ke kakuhle ngendlela le right bani mandimthathe ndimse esibhedlele. Ndimbalekisele phaya esibhedlele kwaze ayikhwelela phaya esibhedlele iambulance. Ndithi kuye iambulance iyeza apha ndiyayazi uba iqhele ukuze iambulance kule ndawo zokuchola abantu. Yani xa ndinantsika ndicela abahlali ndiye.
Ima bhuti omkhulu, yintoni umbuzo wakho?
Ndiza kule ndawo iambulance ziyashota.
Okay.
Ne? Zishota nje iambulance kodwa iambulance zishota nje kodwa imoto iprivate ezincinci zininji zona.
Bhuti omkhulu, ngenxa yexesha ndiyayifumana le nto itshoyo into yoba asifuni usibalisele because nomphathiswa uyahamba. So awuzokwazi uphenduleka bangaba uyatyatyadula. Siyakufumana uthi ambulance iyashota kwabantu abame emvuleni beambulance ingekafiki utsho. All right.
Mna ndicela into eyi-1 nje masiphungule ezi moto ezincinci kongezwe iambulance into iyafika isebenze.
All right, baba.
Nantsi into endicelayo.
Enkosi tata. Ungayicima apha. All right, Minister, before you go, maybe you can some parting shots.
Thanks very much, Chair, and thanks very much to the Vitzenberg Justice Coalition for having travelled all the way here for this meeting and for the engagement. I'm very well aware of the issues that they raise. I know that Dr. Titus met with them last week. Is that correct? So we are trying to resolve some of the issues that are not only in respect of ambulances at the local level, and as the committee can see, we're trying to see on a system level, how do we improve some of these things? And I absolutely agree that there is a lot of power in partnership, because that's the way that we can, add and stretch what we already have. So it's about looking at how do we do that, which is why we've started this think tank. Because very often in the public procurement and private sector is not necessarily that easy to do, but that's not to say that we're not going to try. So that's why we're trying to understand in terms of the rules and regulations, how do we go about doing that? And we do have some partnerships on a local level, but we're trying to see how do we do that province-wide so that we can improve the service that we do have. And if you think that we did over 800,000 trips last year, there will be somewhere where we didn't meet the service standard. But in each case, we want to know about it so that we can look into it, investigate it to see what happened, why did it happen, and how can we improve going forward. We take the attitude that we want to fix and to improve as we can. And then also just to make the differentiation between the emergency services, the ambulances, and then HealthNet, which is the patient transport. There is a significant gap in public transport in rural areas. And that is why we have the HealthNet service to help patients get to our facilities, even though there is no public transport. In some cases, a patient will need medical support during that trip, but very often not. And so we try and do as much as we can through the HealthNet. I think the teams do extraordinary work, but it is quite tough, and sometimes they are oversubscribed. So we are also trying to see how do we make that more efficient by the types of the vehicles that we use. So if on a particular day an appointment system, instead of having a smaller van, we might go with the bus. But it also depends on who is going on that particular day, because there might be 2 people that need a vehicle with wheelchair access. We might need a vehicle where there's a person needs to go on a stretcher because they're not able to sit on a seat. So there's lots of complicating factors in how those fleets are allocated. But we are looking at how do we be more efficient in doing that to make sure that no one is left behind and nobody should be waiting in the rain. So let me leave it at that, Chair. Thank you.
Minister, do you want to add, Mr. Director?
Not much, Chair. I think it's also just important that our planned patient transport, like you've alluded to, it does work on a system where we bring inter-district patients together and then work throughout or across districts to come down to Cape Town. So it looks like this feather that comes in, or fishbone that comes into the city, and that we do definitely endeavour or try to provide facilities for patients to wait at. There is at a lot of our stations, or the purpose-built stations of late, we've been trying to provide spaces that's protected from the weather, where patients can wait.
Minister, from my side, my submission, I'll do it to the think tanks. It is regarding escort in the red zones. I'm just sitting here with an idea, so I will submit that to the think tanks. SAPS versus private security in terms of escorts. I'm sitting with an idea here, but it will need some serious thinking, and it might have some budget implications going forward, obviously, but I will submit it there. Minister, thank you for your time. Thank you for the input. And Dr. Arends and Craig as well, thank you very much. We will then correspond the rest of the thoughts in writing, and to our guests from Vitzenberg, your inputs are noted, and in our deliberations as well, and in our recommendations, and the minister have also indicated that there is a need for engagement, so we will do so, and thank you for coming. Minister, you and the team and our guests, you are excused. There are some tea and coffee in the members' lounge. Please keep some sugar for us as well. We will be coming as members. Members, I'm in your hands. I was going to say we're right on time. Can we just deal with everything and then we know we're done? Another 10 minutes. That's right. Okay. Sorry. Remember, another 10 minutes, then we're done. All right. Okay. Acting Secretary, how are you? Thank you. Thank you. All right. Okay. Bayakhona. Excuse me, ma'am. Are you guys going to the lounge for coffee? All right. We'll see you there in the next 10 minutes. All right, members. Thank you. And then I think we can wrap it up. Can we then just go to recommendations? As the acting secretary. Yeah. Yes, Member van Minen.
Sorry, on a point of order, Mr. Standing Committee meeting, I just want to know, are we now inviting members of the public to engage with standing committee meetings? I'm just a bit confused as to what, whether with Vitzenberg Justice Coalition was here.
That is something that we need to sort out, but in the committee we do get stakeholders, and I do allow them, for limited time to engage, and then we take it from there. Recommendations. Member van Minen.
I think we need to have a recommendation to look at supporting, I don't know if it's an education initiative or a community engagement initiative regarding the interaction between the recipients of the services and the communities with EMS. I'm concerned with what I'm hearing, that people call an ambulance by default. It's not always necessary to have an ambulance. It takes it out of the system. It results in delays. We need to look at some kind of initiative that educates the public as to when an ambulance is appropriate, and the effect of taking a vehicle out of the system and taking a team out of the system, because it means that one is potentially going to have category 1 patients who are going to be waiting 6 or 8 hours because an ambulance and a team is taken up with another matter. I mean, we've seen some public hospitals with triage. And the reality is that someone who's suffering from a heart attack or a stroke is going to be a higher priority than somebody who is just essentially, and I say this with the greatest respect, looking for transport to go and collect medication at a different town. And I don't think the public always understands the limitations of the service. So I really would encourage the committee to start looking at supporting some initiative along those lines. I know it's long worded, but it's just how best I can express it.
Community education in a nutshell. Member van Wyk.
Yes, Chair, I think I would like to support Member van Minen there, because I think it's both education and communication that is needed to get the public to understand these limitations. If you talk about 24 million kilometers in a year, that's 66,000 kilometers a day that the ambulance is doing. So, that extent of trips and what the system has to undertake, I think there's communication and possibly by radio. Just coming into the city this morning, there was Sanral, for instance, gave an explanation of the work that they are doing on the N2 around George at present, and it's very, very valuable in terms of that sort of communicating to get the public to understand the limitations that there are. So I think that's one aspect that we need to look at. The other area is the point that I raised of effectively 200 Rand a year per citizen. If one had that is what we're actually getting this service, this emergency service for. And I think that needs to be translated into some form of, if one had a public benefit organization where contributions could be made both by corporate sector and possibly by individuals to support improvements to the service. I think you mentioned the whole issue of the additional costs, both financially and on this particular service of red zones, and having police escorts and having armed escorts. And it might well be room where you were mentioning that private security could possibly add to something like that. So I think we could possibly then just make a suggestion that the department explore avenues of where a private sector could be involved, or private citizens in providing additional support in terms of some form of a donation or assistance in what has been undertaken.
Member Winful.
I think during the questions I made some recommendations. I'm not sure, Nomonde, did you? That was about the staff and then also the centers. We need, because the presentations is not indicating, they are mentioning communication centers 170. Where are they? And then also they trained about, I think, 10,000. Where are they? So if we can get that type of edit, I think that was. And then lastly, Chair, I think we as a committee, we must also think, how are we going to deal with issues that we pick up during our oversight? Things that are not supposed to be like that. Because for me, doing oversight and just asking questions, more information, what are we doing after that? What are we doing with that information? We know there's a shortage of that. We know there's a problem in that. What are we doing? So we really, as a committee, not only this committee, but we really need to think after that. Can't we say we pick up A, B, and C? Now we need to engage the department on these issues. How will they rectify? How will they, put things in place? So I really want us to think in that line. Thank you, Chair.
So you're proposing all matters raised during oversight visits. We then need to have a follow-up to see what rectifications were put in place. All right. Member Stevens.
Only one thing. I was listening to that lady regarding the ambulances that was locked up behind the gate, and the EMS staff was also there, but they couldn't help the patient. They had to phone Worcester, which is about 45, say about an hour away. What can they do about that? Please, if they can also look into that, because that's, for me, it's not right. There's the ambulance, there's the EMS member, but they had to phone to another place.
Okay, why must Vitzenberg call Worcester?
Why must they phone Worcester? Yeah, if they've got the EMS staff, they've got the ambulance that's locked up, but they can't help the patients. Thank you, Chief.
All right, I understand that, because myself and Member Van Wyk, as previous councillors, with roads, we had the same problem. You see the yellow fleet, and the road is not in good shape, but nobody can do nothing until Cape Town instructs the yellow fleet to react. We'll deal with the wording of that. So I think that is our recommendations in a nutshell. Can we then go to other committee stuff, considerations of and adoptions of these reports? The first one is the 16th of May, our visit to Paarl Provincial Hospital. We've seen the reports on that. Can we go with the adoption of these reports? 16 May. Member Van Minnen proposed, seconded by Member Van Vogel. We also have the minutes of the 23rd. 23rd of May. What did we do on that day? Oh, it is the Tygerberg Hospital visit, and thank you to Member Walters and Member Masipa, who stood in for me there. I couldn't make it. The report is serving. Member Van Minnen proposed, and Member Stevens seconding that. The last one is our visit to Grabouw. And when we got to Grabouw, we were told there was a beautiful lady here who's already been here. And we just put one-on-one together. That was Member Van Vogel. That's why she was not on the trip. Grabouw report, members who were there. Member Van Wyk.
I'll propose there, Chair.
Proposal, Member Van Wyk on the Grabouw visit. Member Stevens seconded that. Then members, thank you very much. Then the meeting is adjourned. All members, next week it is the Overberg trip. And on Monday we'll communicate. We're sleeping over in Hermanus. So we're leaving on Tuesday after one of our committee meetings. We're leaving on Tuesday. We'll sleep in Hermanus. But sometime next week, there will just be a reminder.
Yeah.
Thank you very much, members. Meeting is adjourned.
Thank you.